I'm trying to remember who told me that on the Diabetics Association's website, they actually have a recipe for pudding.
It's so insane. It's so insane. Oh, here's another thing too that's a huge pet peeve of mine. Not a pet peeve. So people of color, like we're all, we're mostly the same, all of us. But so people related to menopause and perimenopause, the white middle-class women are most of the research subjects. So some of the research applies, but not all of it. And it's the same throughout medicine. So Black people tend to have, I think it's 20% lower triglycerides. I think it's 17% higher HDL. So you can miss, if you're looking at those metrics based on what what the metrics for me would be as a person who's like white walls or not even, well, then you're not treating your Black appropriately. And same Hispanic women, they are prone to a horrible kind of breast cancer. If your name is Lopez or Rodriguez, I mean, you can't always tell someone has Hispanic origins, but and we should be attentive to you. The doctor should notice that and say, hey, you might be prone to this, and there are false positives. There are all sorts of problems to overtreatment. But I saw a thing, Scripps Health, and it was some page saying, hey, Black women, pay attention to your cardiovascular health. Do you think they gave the stats for Black women? No. And then also there's a cluster of 5 metabolic conditions that tell you your risk is raised for cardiometabolic diseases, and they're high blood sugar, high blood pressure, visceral fat, which is that when you have belly fat, that it's basically around your organs. Really,
I call that Dunlap's disease. It's where
so
your belly
scary.
Dunlap over your belt.
What did you say?
I call it Dunlap's disease. That's where your belly Dunlap over your belt.
And I love that. And then the other things are, let's see, what are the other two? High blood pressure, high blood sugar. Okay. Missing one of them. High triglycerides and low HDL. Right. And so if you are a white person and you have 3 of those, that suggests you have elevated cardiometabolic risks over like heart attacks, diabetes, and all these conditions, stroke. If you're a Black person, 2 out of those, that suggests elevated risk. This needs to be explained. It's malpractice to not treat people as individuals in these meaningful ways when we have this information. Same as the gynecologist. Oh my God, the 5,000 word like rebuttal that I had to write about all the stuff they got wrong, because I want to lay that out. It's not right that they don't know this stuff. But, they're denying me. I want an increase in my estradiol prescription since I have this high SHBG. I rapidly metabolize the estradiol, and then I have the modafinil tanking my estradiol levels further. And these have been tested. So we see it's not like I'm just guessing this stuff. And they're refusing that. They said the head of gynecology tells me it's a super physiologic dose that I'm asking for. It might be in someone who is not Amy Alkon, but in me, it's what would be necessary to protect me. I'm like 61. I've been in menopause I still have hot flashes, and I've had symptoms that have come back because of it's medical harm. It's called iatrogenesis, when a doctor means to help you, but they harm you. That's the cortisol, where the doctor gave me a corticosteroid overdose for my eyes. These drops, they go systemically, crazy, and this woman, head of gynecology, and she's saying this, and I explained to them, look, here are the reasons. And so treating an individual means giving them, treatment according to their individual, and this is something that's just not done. And doctors, there's a defensive medicine is being practiced, and that's when doctors, they don't know. They're ignorant of something, and ignorant is such a rude word, but it's the case. She's ignorant, of this tapering at 60, all this stuff that she put forward in my appointment, and then they deny you care out of, either they'll give you excess care or insufficient care based not on what is best for you, but based on their need to protect themselves from being sued. And then also less malevolently, doctors don't want patients to come back in. My transplant surgeon, she's wonderful, despite, she doesn't know about steroids. And there's a reason she shouldn't be expected to. They should have experts in that area. But, she doesn't want patients coming back and crying in her office that they're losing their vision in the transplant eye. This is horrible. And it's a privilege. Someone gave me donor tissue. This is why I'm an organ donor. I started to cry when she told me I'd get donor tissue for my eye. And, my mother had this disease too, by the way. So thanks, Mom. And so I can understand that she doesn't want those patients coming back. And then on a careerist level, you don't want your surgical record to be, a bunch of these failed. So, there are reasons for this, but that doctor, knowing steroids takes and careful prescription of them and all the parts of the body that are related. This is a whole huge transdisciplinary area to understand. And it is unreasonable. She's an elite eye surgeon. It is unreasonable to expect her to keep up on the stuff in her field. And you really want her to, because remember, she's sticking an X-Acto in your eye. And then also understand the whole area of steroids and everything related, the neuroscience. It's called, touching my head, it's called the HPA axis. That's what's malfunctioning in me because of the overdose she gave me. That's the hypothalamic pituitary adrenal axis. And there's signaling that goes on. And she basically suppressed my immune system by this idea that in their field, when they do these corneal endothelium transplants called DMEC surgery, it's the least rejected there is of transplants because you don't have blood vessels. It's not vascularized in your cornea. So you're less likely to reject. It's like 0.7% possibility of rejection. And probably the metabolic healthy patients are the ones who reject it, and so, the steroids area, the field, it's just out of clinical habit. They think it's evidence-based that they prescribe 4 drops for a day after your surgery to keep your inflammation down and help you hang on to your transplant. But it's just based on clinical habit. And nobody compares, what about this or that? And these steroid drops are pernicious. And here's the other thing. This is how unscientific medicine is. They give you a Kaiser and other places too. You get these prednisolone acetate drops and then antibiotic with back preservatives in them, BAK. Parabens are also bad in eye drops, but they're about to ban these in Europe. And they begin to destroy your cornea in a matter of days. This is like, we got to destroy the village to save the village. We're just destroying the village. And so I'm sorry. I would prefer not to take those. Also, a dry eye and the stuff that makes it even harsher for me. And this is this unquestioned thing. I had asked a doctor there before I got to the cornea surgeon, an appointment with a cataract guy. He had prescribed me eye drops and they had preservatives. And I said, can you prescribe some without preservatives? And he said, are there such a thing? Hey, do I need to be the medical genius in every area? And I say that with, sarcastically. I didn't know. So he says it to me. So I'm like on the phone and like with the pharmacy and like asking some pharmacist and like looking things up. Like, why is this my job? I can do it and I did and I had to, but like, this is insane. The problem is if you're not me, I'm a psychotic nerd. I will I will exhume a body from like 1940, who died in 1943. The scientist died with one piece of paper and his cremains or whatever's left. He's still got the paper that shreds. I'll have him exhumed to read that paper. But, is it too much to expect that our doctors would just be basically evidence-based? And again, not all, are this way. I told you my psychiatrist, wonderfully evidence-based. He uses pharmacogenetic testing. I didn't even know Kaiser had that, but he does it because it's important. This allows you to know what someone's genetics are, as I had mine done, to know, how do you metabolize this drug? Does this drug work for you? Do you need more of this drug? What drugs don't work for your genetics? These various liver enzymes. And it's so important. And so he's providing the most individualized care to his patients. It's really, really important, especially with mental health stuff. There are people who have, I love the bright lines of mental, you have bipolar disease. My God, they have to do that to give them drugs like the DSM, this mess of a Bible of the additions. But, people don't have bright lines around disease. They have this symptom or that symptom. And there's this attempt to name it something. And then the insurance will then pay for, we, give you this drug for this. But that's not scientific and it's not good medicine in many cases to just, have to settle on a diagnosis of something specific when, this and that and the other thing in a kitchen sink are involved.